Welcome to the National Clinical Care Commission. My name is Jennifer Gillison and I'm from Kaufman Associates and will be supporting the meeting today. I'd like to start with explaining a little bit about the webinar interface. You should all see the first slide on the PowerPoint presentation in the middle of the screen and the Q&A box open to the right of the slide. If you need technical assistance during the webinar, please type the issue into the Q&A box and one of our techs will respond to you. We are only able to use voice over IP today, so there are no phone lines. All other computer lines have been muted, and please note the webinar is being recorded. I will now turn it over to the DFO.
Good morning to some and good afternoon to others, but welcome everyone to the first day of the 11th meeting of the National Clinical Care Commission. I will now call roll. Members, please let me know you are here when I call your name. Bill Herman, Chair.
Present.
Pat Schumacher. Please let the record reflect that Pat Schumacher will be attending, but due to a prior commitment, she will be running late. Oh, could everyone please mute their mic? Thank you. Howard Tracer?
Here.
Barry Mark?
Present.
Naomi Sukadewa?
Present.
Donald Schell? William Chong?
Present.
Aaron Lapata?
Present.
Dana Town? Bartender? Present. Could everyone mute their mic, please? Captain Samuel Wu?
Present.
Paul Conlon?
Present.
Ayatani Dokun? Carol Greenlee?
Present.
David Sturgod? Dean Schillinger?
Present.
Ellen Leak? Jasmine Gonzalvo? Present. John Boltry?
Present.
Meredith Hawkins?
Present.
Shannon Idzik? Sherry Boland?
Present.
Bill Cook?
Present.
Dr. Herman, there is a quorum, and usually I would pass the mic to you, but would you like us to first give Jana Town, as the new Indian Health Service representative, a few minutes to introduce herself to the committee?
Sure, that would be great.
Good morning, good afternoon, depending on what part of the country you're in. My name is Jana Town. I am, as noted, the new representative from the Indian Health Service as Dr. Bullock has retired. I work with the Division of Diabetes Treatment and Prevention as well. Joined the committee approximately a month ago and am excited to be part of the group. Thank you.
Great, welcome. Kara, are we all set? Shall I go ahead?
Yes, please, thank you.
Good. So I too want to welcome you to the 11th virtual meeting of the National Clinical Care Commission. If I can have the next slide. But by way of background, the National Clinical Care Commission was established by the Secretary of Health and Human Services to evaluate and make recommendations regarding improvements to the coordination and leveraging of programs within the department and other federal agencies related to awareness and clinical care for diabetes. Next slide. The enabling legislation for the National Clinical Care Commission states that the Commission shall evaluate and make recommendations to the Secretary and the Congress regarding federal programs that focus on preventing and reducing the incidence of diabetes, current activities and gaps in providing integrated high-quality care, the improvement in and improved coordination of federal education and awareness activities, which may include the utilization of new and existing technologies. Next slide. Methods for outreach and dissemination of education and awareness materials for healthcare professionals and the public, and opportunities for consolidation of inappropriately overlapping or duplicative federal programs. Next slide. The work of the Commission has been carried out by 3 subcommittees and a work group. The subcommittees have focused on the prevention of diabetes in the general population, prevention in the targeted population, and treatment and complications. The work group has addressed the broader issues of access to health insurance, making medications affordable, and new delivery and payment models to improve diabetes prevention and care. In addition, all of the groups have focused on the cross-cutting areas including social determinants of health, health equity, and research. A lot has been accomplished since our last meeting on February 17th. Stakeholder and key informant calls continued until the end of April. Draft recommendations were revised and shared with stakeholders and key informants in May. Their comments were received, reviewed, and addressed by the subcommittees and the work group, and work has begun on reconciling and integrating the revised recommendations across the subcommittees. Today we'll review and discuss the recommendations, focusing on the revised and new recommendations, and we'll begin to prioritize them. At the second half of this meeting on Tuesday, June 22nd, we will vote on the final recommendations to move forward, finalize the structure of the report to Congress, and assign writing groups. The subcommittees will complete their writing assignments by August 20th, and the Commission will meet on September 8th to vote to approve the final report. The report itself will be submitted to the Secretary of Health and Human Services and the Congress by September 30th, 2021. So this is now a very exciting and fast-moving time for the National Clinical Care Commission. And without further ado, I will turn it over to Aaron Lapata and Dean Schillinger, the co-chairs for the Prevention General Population Subcommittee, to provide their update. So, Aaron and Dean.
Thank you, Bill. Hello, everybody. Before we begin, a couple of comments. First is that we are presenting our final draft recommendations to you, so the entire portfolio of recommendations. Second, I wanted to acknowledge, and I imagine this will be the case with the other subcommittees, that we have received all the public comments and have incorporated revisions to these recommendations based on those comments that were deemed to be relevant and assist us in refining our recommendations. And lastly, before I jump in, there has been some question about the title of our subcommittee, and it's been quite a long time since we developed this title. I think you can think of our committee as a committee that is focused on population-level policies and practices to prevent and control diabetes. So the programs would benefit those with diabetes, those with pre-diabetes, and those at risk for having either, which, as it turns out, is a significant proportion of the U.S. population. The members of our it's not actually, this does not include Jana, who I added yesterday. That's strange. Anyway, the members are Bill Cook, Jasmine Gonzalvo, Carol Greenlee, Bill Herman, Naomi Fukagawa, and Jana Town from the Indian Health Service, whom you just received an introduction from. We, as a National Clinical Care Commission, did a tremendous amount of work in the first year as an entire commission, trying to define the scope of the work of our commission, and came up with our 3 subcommittees and 1 working group, as you heard Bill describe. When the commission's work got transitioned to the Office on Women's Health about 12 months ago, some questions arose as to whether specific recommendations were aligned with the NCC charge. So I wanted to, before we dive into the 12 recommendations of our subcommittee, just frame again for the Commission and for the general public where our recommendations are coming from with respect to alignment with the duties that Bill Herman just reviewed. Duty 2 is related to our work is to ensure high-quality integrated clinical care can be provided to patients with diabetes. And as we reviewed a few years ago, many individuals in the United States with prediabetes and diabetes have inadequate resources or unsupportive environments with respect to the prevention and control of diabetes, which significantly undermines clinicians' abilities to prevent diabetes or manage diabetes and prevent its complications. Research has demonstrated that diabetes patients' social, material, and psychological needs strongly influence both diabetes incidence and outcomes. In fact, many clinicians report high levels of frustration and burnout because the systems in which they work and the systems in which our patients live do not take such needs into account, which undermines our ability to care for the diabetes or self-manage the diabetes. Given this research and now general realization, what now is considered to be high-quality diabetes-related clinical care has evolved. Contemporary care now involves a more comprehensive and holistic approach that combines the so-called traditional model of care, which is medications and lifestyle counseling, with a more integrated patient-centered model that includes robust clinic-community linkages. And as any of you know who practice with patients with diabetes, clinic-community linkages often involve referrals to programs, many of which are funded or directed by federal agencies that offer basic goods and services, for example, nutrition, housing, and transportation assistance, among others. Integrated models of diabetes care that extend beyond the four walls of the clinic and link patients to effective community resources and programs have been shown to improve outcomes and reduce costs. A number of organizations all endorse this integrated model for chronic disease care. However, no prior formal assessments have been made as to whether the designs of such federal programs actually help prevent diabetes or its complications, specifically the extent to which such programs meet the needs of individuals with prediabetes and diabetes. Such individuals represent nearly half of U.S. adults and roughly two-thirds of all U.S. adults eligible to receive public assistance. As a result, the NCC determined that it is critical to assess how a range of federal programs that influence the lives of individuals with or at risk of diabetes and its complications can be leveraged and coordinated to enable the integrated model of care to achieve its objectives. This not only supports clinicians caring for individuals, but also increases the return on investment for federal expenditures by ensuring that any given federal program, for example, the SNAP program, which is part of USDA, can enhance rather than undermine the efficacy of other federal programs such as Medicare and Medicaid. In 2019, the NCCC carried out a federal agency-wide survey and determined that with rare exception, non-health federal agencies are not aware that their programs and activities can influence diabetes prevention control efforts. In addition, they have not designed their programs and activities in such a way as to support such efforts. In fact, in some instances, the work of such agencies unknowingly undermines the efforts of clinicians and their patients across the diabetes care continuum, as well as conflict with the efforts of federal healthcare and public health agencies to support clinicians with respect to the prevention and control of diabetes. In 2020, we conducted a systematic literature review and synthesized the evidence on activities related to federal programs hypothesized to influence diabetes incidence, control, and complications. Based on this work, the NCCC General Population Subcommittee developed recommendations related to Duty 2, which is the ensuring high-quality integrated clinical care. Similarly, our recommendations are aligned with Duty 3, promote federal education and awareness activities. The rationale for this is that the health literacy of a significant segment of U.S. adults is inadequate. Nearly half of individuals living with diabetes have limited health literacy. Individuals with diabetes who are beneficiaries of federally funded programs have even higher rates of limited health literacy as populations disproportionately affected by type 2 diabetes, such as certain racial and ethnic minority subgroups and those with limited educational attainment. Limited health literacy has been shown to independently contribute to diabetes incidence, and among individuals with type 1 and type 2, limited health literacy results in worse metabolic control and higher complication rates. Individuals with limited health literacy have been shown to have less awareness of evidence-based strategies to prevent diabetes, and among those with diabetes, less awareness of strategies to successfully manage diabetes and prevent its complications. Limited health literacy has found to be the strongest independent predictor, for example, of the consumption of sugar-sweetened beverages, a significant driver of diabetes. Comparing those with the lowest to the highest health literacy demonstrates that a difference of 240 calories per day, equivalent to a difference of one daily 20-ounce Coca-Cola, can be attributed to health literacy alone. Clinicians often struggle when attempting to prevent and manage diabetes for their patients with limited health literacy and report that their patients need additional community-level support to enable effective care. A number of federal agencies, many of which have very broad reach, support and direct programs and engage in activities that can significantly influence the level of public awareness related to diabetes prevention control. These include the CDC, NIH, FDA, USDA, and the Federal Trade Commission, among others. As a result, our commission assessed such programs to determine the alignment of their educational activities with the goal of increasing public awareness regarding ways to prevent and control diabetes across the lifespan. In addition, our subcommittee conducted a systematic literature review and synthesized the evidence related to federal programs' diabetes-related awareness and communication activities. Based on these assessments, we developed our recommendations as they relate to Duty 3. Now, to move on to the recommendations, let me just say you all have seen the vast majority of these recommendations before. As a result, for those recommendations that we already have discussed and achieved preliminary consensus around as a full commission, I will just restate the recommendations and not the background and rationale in the interest of time. If, however, individuals have questions as to their rationale, please feel free to raise your hand and put out a request, and we can address that on this call. So recommendation number 1, which I will preface by saying there is a potential interest in having this recommendation be adapted to be subcommittee-wide, involving all subcommittees, is that we recommend the creation of an Office of National Diabetes Policy in the Domestic Policy Council of the Executive Branch to develop and implement a national diabetes strategy that leverages and coordinates the work of relevant federal departments and agencies as outlined in our report. The ONDP would have as its primary responsibilities to facilitate coordination among federal agencies with respect to trans-agency approaches to preventing and controlling type 2 diabetes, make recommendations to the executive and legislative branches regarding actions they can take to prevent and control type 2 diabetes, advance a health in all policies agenda with respect to diabetes, promote the use of health impact assessments for relevant policies across non-health departments and agencies, and establish the conditions and methodologies for health impact assessments, entities to conduct health impact assessments, identify resources and mechanisms to generate health impact assessments, adjudicate and implement health impact assessment recommendations, and train the skilled workforce necessary to carry out health impact assessments. We also recommend that the Office of the Secretary of Health and Human Services establish a process within the department to work with the ONDP to foster broad trans-agency collaborative work between HHS and non-HHS federal agencies aimed at positively changing the social and environmental context that accelerate the type 2 diabetes epidemic. And Kara and Bill, I don't know if I should be stopping after each recommendation. I will now to, unless you say we should go through them all and then open it up for conversation. Please advise.
Briefly, if there are burning questions or clarifications.
Okay, let me pass the baton to my colleague, Dr. Carol Greenlee. I apologize for the small font, but this turns out to be a very important recommendation, and the details are necessary at this point in time. Carol?
Thank you. Yeah, thank you. So the overall recommendation is that there's an update or modernization of the USDA Supplemental Nutrition Assistance Program, or SNAP. These updates can occur at the level of USDA or at legislation via the Farm Bill. There have been alterations or modifications since you've seen these recommendations. The first is 2A, that the adjustments to SNAP made during the COVID-19 public health emergency should be extended until more permanent adjustments can be legislated through the Farm Bill in 2023. We also added 2B, the USDA should assess the adequacy of the current SNAP benefit allotments to see if they meet the food and nutrition security as defined, so as to ensure that the benefit is adequate, and then establish a process to reassess the adequacy on a regular basis. So adding sort of an ongoing evergreen component there, we suggest every 10 years. We shared with you last time the formula, the recommendations to adjust the formula around SNAP benefits, and we've retained those with them detailed in the report. We also recommend that incentive programs around the food and vegetable incentives be implemented at least 30% incentive. That means reducing the cost of fruits and vegetables to SNAP beneficiaries, and that sugar-sweetened beverages be eliminated as allowable SNAP purchases. We also recommend that there are enhancements to SNAP to enable its access and use, including working with states to streamline the application process. And this would increase the number of people who are currently eligible for SNAP so that more of those people are able to receive the benefits, increasing public awareness of the benefit and how to access it, increasing the number of sites that accept SNAP, and helping stores in rural areas and food deserts meet the minimum stocking requirement. We enhanced 2G to say improve and expand diabetes and nutrition education and awareness programs for beneficiaries to increase fruit and vegetable consumption. Just to explain there, putting the incentive in place isn't enough if people don't understand what that means and how to use it. Reduce added sugar consumption, and increase media and marketing literacy. And in addition, we think that SNAP Ed should focus more on policy, systems, and environmental approach, not only on one-to-one counseling. And then we added to H that the USDA should incentivize the testing and implementation of innovative state-level policies, practices, and programs designed to reduce geographic, racial, ethnic, and linguistic disparities in SNAP enrollment and retention. So happy to take comment or feedback on this recommendation.
And as you all are cogitating on that, I wanted to publicly thank Carol Greenlee. This is, as you can see, a tremendously complex program in need of improvements with respect to diabetes prevention and control, and she's done a tremendous amount of work with our subcommittee to get this recommendation to this point.
This is John Boltry. I have a question on 2H.
Yes.
So how could the USDA incentivize the testing and implementation of what you're suggesting there?
So this is aimed at trying to figure out if most of this is aimed at ensuring that people who are currently eligible for SNAP get the benefits that they need to have food and nutrition sufficiency and or receive SNAP. This latter one is a way to look at whether there are things that can be done to expand the eligibility and then help retain people in it. And right now, I can't give you an example of an innovative state-level initiative. I can try to get some examples, and we can put them in the report if you think that would be helpful. I apologize.
Carol, yeah, I could jump in, Carol. There's John. There's tremendous state-to-state variation in the enrollment rate for SNAP-eligible individuals. Just one example would be the degree to which programs have outreach in different languages and enrollment forms in different languages. Incentivizing states to create outreach materials and enrollment materials in minimum criteria languages would be one example of what Carol is describing here.
So do you say that in your background, there's state-to-state variability? Is that clear in the background?
We have not, but we can certainly include it. It's a helpful comment.
Yeah. The difficulty in signing up for SNAP varies across states, too. So that's 2G, or 2F, I'm sorry. The barriers to enrollment are overwhelming in some states.
And maybe we could put 2F and 2H together in that way to tighten things up. Carol, what do you think?
Okay. Good idea.
Hi, this is Sherry. I just had a question about 2G. The last part of the sentence, the additional SNAP Ed allocations should be made to support, policy system and environmental approaches rather than one-on-one counseling. So I guess it's just a question. Is the SNAP Ed, are they allowed to do that kind of work, or does that work have to be done somewhere else? It was just sort of a, because I think you're getting at sort of policy systems and environmental approaches to improve dietary. So I didn't know if that was more in the CDC realm or if that's something.
No, they are allowed to do that work. In fact, the USDA is funding a number of states' health departments to do that work. It's just a very small amount of funding despite the successful outcomes.
And is it duplicative at all of what CDC does? I know one of the things we're supposed to address is duplication of effort.
To my knowledge, it is not. For example, some policy systems and environmental approaches that the USDA SNAP Ed program would support would include school-based, trying to change practices in schools. That level of reach the CDC simply does not have.
Okay. Thank you.
Should probably move on, Dean.
So let me pass to my colleague Aaron Lapata, who's going to speak about the non-SNAP USDA nutrition assistance programs.
Sure, thank you, Dean. So yeah, this is recommendation 3 to improve nutrition for children through the USDA non-SNAP nutrition assistance programs related agency efforts. So our first recommendation here, 3A, is to further strengthen the WIC program by sustaining the evidence-based prescriptive WIC food package, expand funding for breastfeeding peer counseling service, invest in improvements to information systems and technologies to enable greater access and service for WIC participants. Next recommendation is to maintain the nutritional standards found to be salutary in the Healthy, Hunger-Free Kids Act. Next recommendation is to provide adequate funding for first, schools to purchase, prepare, and serve healthy, quality foods and beverages for school meals and snacks to meet the HHFKA, which is again the Healthy, Hunger-Free Kids Act, nutrition standards, and second, to deliver training and technical assistance to support maintenance and payment of the Healthy, Hunger-Free Kids Act nutritional standards and skills to run such a program. 3D, in collaboration with the Department of Education and EPA, recommend that USDA ensure that all students in public schools have access to safe, appealing, and free water. This includes providing water and drinking vessels access located in strategic locations across campus, developing an incentive program to enable schools to cover implementation costs, tying receipt of federal funds for school-based food programs to water access, providing funding to upgrade plumbing and facilities in schools to ensure access to clean and safe tap water, including earmarking proportion of federal resources provided to local education authorities to improve healthy, safety conditions in K-12 schools via the American Rescue Plan. And then also creating and implementing uniform national lead testing policy and methods for schools and child care settings. Temporary exemptions to the water accessibility requirements could be made for regions that do not have safe tap water and or incentives that should be provided to such sites to encourage provision of clean filtered water. Next slide, please. Next recommendation is to prohibit sale of unhealthy foods, beverages, known as junk food and SSBs, at public schools and employ incentive programs to enable schools to cover essential costs, such as those for physical activity, athletic programs, and previously underwritten by sales. Receipt of federal funds for school-based food programs should be tied to implementation of such restrictions. 3F, strengthen and improve access to and participation in summer feeding programs, including innovative partnerships between public and private sectors in rural areas and other high-risk areas where participation has been low. Further increases in program participation should be achieved by offering a summer EBT benefit, whereby youth in the National School Lunch Program receive SNAP-like benefits for healthy foods over the summer, reducing the need to go to a specific participating location to get meals. The food and beverage package covered by this benefit must be aligned with the nutritional standards of the HSFKA, again, the Healthy Kids Food Act, and summer feeding programs. Funding for the program should be increased to enable scaling to meet population needs. The next recommendation is continue the use of USDA waivers and innovative strategies that have been used by the Summer Food Service Program and the Seamless Summer Option. Those are both part of the summer feeding programs of USDA. We want to recommend continued use of the USDA waivers and innovative strategies for those programs that have been used during the pandemic, which have been found to strengthen the program. We will recommend continuing those waivers and innovative strategies through the end of pandemic and beyond the pandemic, which have all been demonstrated to strengthen the summer feeding programs. And the final recommendation is to strengthen and expand the reach of the successful fresh fruit and vegetable program for elementary students from economically disadvantaged families to support a reduction in diabetes through improved dietary quality. Funding for the program should be increased to enable scaling to meet population needs. And if anybody, I know that's also a lot, there's a lot of detail in these recommendations. I think you've heard most of them. The second to last recommendation regarding the waivers and innovative strategies used during the pandemic that we want to continue is new. I think you're familiar with the other ones, but please let me know if you have any questions. It's a lot to take in, I know.
Putting up the recommendation again so people can see.
Paul Conlon, I do have a question about recommendation 3E, mainly just a clarification where the word junk food is used or sugar sweetened beverages. Junk food is one of those things that people may know it when they see it, but usually when policies are written, they need to have better definitions, and that could be interpreted very differently by different people. Is there some way that that recommendation could provide either some clarity, maybe not necessarily in the recommendation or maybe in the background, that gives better definition of what it is that you're intending to limit access to?
Yes, I mean, I think that's a really good point. I do think we will have to be more specific and define that more clearly. I think we have discussed that. It may or may not be in the background, but we will definitely make sure that's clarified and that there's a definition for that, because otherwise, yeah, that would be it'd be open up to a lot of criticism and different interpretations. So I think you want to be very specific there. Dean, did you have any other thoughts?
Thank you, Paul. And just to say that we did discuss this at our last subcommittee call, and we're hovering around defining it as calorie-dense, nutrient-poor foods based on the Dietary Guidelines of America definitions.
That would be great if you could link it to something that has been vetted. I do have one other comment, and that relates to recommendation 3D, G as in David, on the prior slide. And this recommendation includes an incredible amount of detail. I applaud you for taking the effort to write something with such detail. I was a little bit pausing on the bullets that are labeled 4 and 5. My initial concern is that those may extend, albeit obviously very appealing, may extend a little bit beyond what it was that I think you're trying to accomplish. Certainly the beginning of the statement where you say provide access to safe, appealing, and free water would encompass most of what follows. What I wasn't clear on is whether or not extending resources to plumbing or to lead testing is necessarily something that we should go into as a recommendation from our commission.
Yeah, this gets to the question of to what extent can we provide content to Congress about the how as opposed to the what. And I think that is a very important decision we'll need to make as a group. I think we're all grappling with that. I would say we are not wedded to these these little Roman numerals here. They're just, as you implied, strategic opportunities for implementation of the recommendation. But whether we can and should include them in the recommendation or in the background report with respect to that level of detail, I think we'll have to defer to the group discussion as we're writing.
Okay, thank you. I have no other comments.
There's no question we could get them out of the recommendation. Whether we want to include them in the larger report, I think, is really the larger question. Any other questions about recommendation 3? It also is quite a meaty one.
And Dean, just for a time check, you have about half an hour left.
Great. Recommendation number 4, Aaron, I think you can go through this one quickly. You may be muted.
Yeah, meet you automatically if you don't talk for a minute. I apologize. So this is our recommendation 4, modify USDA programs that support farmers to make the U.S. food supply healthier. The recommendation broadly is that USDA should increase its support for programs to change the food supply and healthy food access in the U.S. so as to promote the prevention and control of diabetes by first, significantly expanding and increasing funding for the specialty crop block grants to support food safety and drive demand through education for specialty crops, such as fresh fruits and vegetables and tree nuts, to increase dietary diversity to help people achieve the dietary guidelines for Americans. Second, significantly increase funding for the Specialty Crop Research Initiative grants for research on how to improve specialty crop production efficiency, handling and processing, productivity, and profitability over the long term, including specialty crop policy and marketing. 4, significantly expand and increase funding for the Evidence-Based Healthy Food Financing Initiative, which is a federal effort to improve food access and health in low-income, underserved communities and communities of color in urban and rural areas that support farmers and healthy food retailers to improve access to nutritious, affordable, fresh food. And finally, expansion and funding should be implemented to achieve population-wide benefits by 2030. And again, I think everybody's seen these before, but again, please let us know if there's anything you're seeing newly or have any questions about.
Okay, I'll move on.
So I have a question.
Recommendation. Oh, go ahead. Yes.
It's regarding specialty crops. Is there a specific definition, and does that exclude crops that are not helpful for preventing diabetes or for people with diabetes?
There were a lot of double negatives in your question. Can you restate that?
Sure. Just what I'm asking is, are all specialty crops healthy for preventing diabetes or for treating people with diabetes?
If I remember, I think they are. I don't remember seeing any specialty crops that were unhealthy. So I don't know if they were all. I mean, this is about healthier diets to prevent diabetes. I don't think there's anything that any of the specialty crops that would worsen or make it worse or were unhealthy for you. I think they were mostly crops and that were leading to foods that are healthy, but they're just not necessarily very profitable. And I think it was in the public interest to fund these healthier crops, which is why the program exists. So does that help answer your question?
Naomi might know. There is a list, and I don't know that we've done a one-to-one, so Naomi might know.
Yeah, so I'm here, and it generally is considered healthy, but in theory, these are crops that are really intensively cultivated, and usually cultivated for the reasons of either sustainability and or potential nutrient and bioactive compound content. So in some ways it is a specialized area in ag, but the types of foods that we're considering that are associated with health benefits oftentimes fall into this grouping.
That's what I read, was there are crops that are highly cultivated, and that's why
Correct.
I'm wondering if it could also, if this broad of a brush could include crops that maybe are not the kind that we want to promote. That was just what I was wondering.
Yeah, and I think it's a good question that we should, Aaron, just to run the list of what's included in specialty crops to make sure that we're not inadvertently promoting diabetes.
We could do that. Yeah, absolutely.
And it's fruits and vegetables, tree nuts, dried fruits, horticulture, and nursery crops, including floriculture. That's how it's defined in the Farm Bill. And that most people aren't going to eat flowers, but you can. But I think it's, I don't think they would be harmful to diabetes, but I think it doesn't have anything on the list as defined in the Farm Bill that would be harmful.
Right.
Right.
Thank you.
Thank you. So let's go to recommendation 5. You've seen most of these recommendations, although we have merged recommendation 5 and 6 together, and we have focused more on including water as a way to frame these recommendations. So the recommendation is to encourage the consumption of water over sugar-sweetened beverages. First, the USDA should add a symbol for drinking water to the My Plate graphic and increase water promotion messaging in all consumer-facing materials issued by its Center for Nutrition Policy Promotion. Water is not currently depicted on My Plate. 5B, child nutrition programs should be a conduit for education to promote consumption of water and reduce consumption of sugar-sweetened beverages. USDA should encourage healthy hydration and provide safe water education in WIC nutrition education and in child care settings. Congress should harness the child nutrition reauthorization to strengthen existing water provisions for school nutrition programs. 5C, the Department of Health and Human Services should commission a scientific report. I'm sorry, I should say 5C comes in response to 2 or 3 public comments that we received. The Department of Health and Human Services should commission a scientific report of the evidence regarding the causal relationship between sugar-sweetened beverage consumption and diabetes under the auspices of the U.S. Surgeon General, CDC, and/or NIDDK. Contributions should be made by experts in diabetes in clinical medicine, nutrition and metabolism, epidemiology, and public health and health disparities. Experts must be free of food and beverage industry conflicts. And the rationale, I should say, for this recommendation is the observation that a number of local and state initiatives regarding curbing sugar-sweetened beverage consumption have been challenged because the federal government has not made clear its position on the science behind such recommendations. 5D, the CDC and NIDDK should develop and implement a national campaign and associated materials to both promote the consumption of water and reduce the consumption of sugar-sweetened beverages as a strategy to promote overall health, including the prevention of obesity, diabetes, and cardiovascular disease. The CDC should include such messages across all of its relevant programs, including the National DPP program and its associated DPP curriculum. That's something that obviously we're handing over to our colleagues in the other subcommittees, so we could take it out of here if it's more appropriate. 5E, all federal agencies should promote drinking water and reduce sugar-sweetened beverage consumption within their own organizations and through the grants and programs they fund or administer. All agencies should increase access to free, clean, and appealing sources of water for their employees and visitors. Water sources should preferably be tap water, but in sites where the tap water is known to be contaminated, filtered or bottled water is acceptable. And agencies should develop procurement and other policies that curb the availability and sale of sugar-sweetened beverages. 5F, the Department of Health and Human Services should serve as a federal model by A, ensuring on-site access to safe, clean, and appealing water, and B, prohibiting the sale of sugar-sweetened beverages in DHHS government-owned or leased offices, workplaces, and healthcare facilities. They should collaborate with CDC or NIH to formally evaluate implementation, employee behavioral change, and diabetes-related outcomes. 5G, the U.S. Treasury Department should impose an excise tax on sugar-sweetened beverages to cause at least a 10% increase in their shelf price, in addition to a base tax rate of 10% to stimulate reformulation by industry. Calculations regarding the amount, the maximum amount of the tax should consider a graded taxation model based on the amount of added sugar included in sugar-sweetened beverages. The revenues generated should be reinvested in a manner that promotes the health of those communities that bear a disproportionate burden of type 2 diabetes. This federal sugar-sweetened beverage tax should not serve as a means to preempt state or local authorities from also levying their own additional excise tax on sugar-sweetened beverages. And finally, the Office of the U.S. Trade Representative should ensure that all international trade agreements allow for the taxation of sugar-sweetened beverages and front-of-package health advisory labels and icons that we will discuss in our next recommendation. Questions or comments? Okay, recommendation number 6 is a slightly modified recommendation based on public comment and review of key informant. This relates to food labeling, enhancing FDA's role in preventing and controlling diabetes through new labeling requirements. We recommend that the FDA improve its food and beverage labeling regulations that influence industry practices so as to better prevent and control diabetes, including implementing a new national, compulsory, uniform, simple, and easily recognizable and understandable front-of-package icon system that alerts consumers to the health attributes or health risks of food and beverage products based on their ingredients. The front-of-package icon warning system should be informed by evidence accrued from epidemiologic, clinical, and nutritional sciences, and its design should be informed by health communication science. 6B, the use of teaspoon units in addition to grams for added sugar content contained in the product in the revised nutrition facts label should be implemented to enable consumers to accurately assess their added sugar intake relative to daily limits. To clarify, right now, added sugar is communicated in grams. The average American does not understand what that translates into in common parley, and so we're recommending the use of teaspoon units to be included. 6C, insofar as the added sugar label is a new innovation for the FDA, a robust multilingual communication campaign related to its new added sugar labeling and its rationale should be conducted. 6D, the FDA should update its policies and regulations so as to prevent industry claims on food and beverage products that mislead U.S. consumers to believe that unhealthy foods are healthy. As examples, we recommend that the FDA should include added sugars to their existing regulation that disqualifies the use of health claims if a product contains excess levels of total fat, saturated fat, cholesterol, or sodium. So we're recommending that they add to the list added sugars. B, setting new science-based standards regarding the use of the term whole grain in foods. Right now, you can have 2% of your bread include a whole grain product, and it can be labeled as whole grain. And lastly, regulating standards of identity, labeling, and claim allowances under a new type of food known as toddler drinks, prohibiting the use of the misleading terms such as milk, formula, and recommended or necessary, and mandating scientific evidence for all health claims, and requiring disclaimers that such products are not intended for children less than 12 months or as a substitute for breast milk or infant formula. That is it for recommendation 6. Any questions or comments?
A question on the added sugar, 6A. Would that be any amount of added sugar?
I think we would, that's a very good point, because there currently is a recommendation for excess levels of fat, sodium, etc. So we would have to add a qualifier into that recommendation. Thanks for that comment. I believe that the existing regulation that disqualifies the use of health claims includes a definition of excess. Any other comments on recommendation 6? Recommendation 7 is a new recommendation for the Commission, so I will read the rationale. Rates of type 2 diabetes have been increasing among U.S. youth of color, in particular, with rates tripling among Native American youth, doubling among black youth, and increasing up to 50% among Latinx and Asian Pacific Islander youth. The expansion of the epidemic into children and adolescents in large part is a result of a food environment that increasingly promotes unhealthy dietary patterns. The unfettered advertising and marketing of so-called junk food, we will redefine, to children through television, film, social media, and other internet platforms, including marketing campaigns targeting children of color, have been shown to be significant drivers of the consumption of unhealthy food and beverages among children. Children less than age 13 have been shown to be especially vulnerable to industry messages. They also lack the critical media skills to detect when they are being deceived. Over a decade ago, the Federal Trade Commission examined and exposed those industry practices that were contributing to the obesity and diabetes epidemics in children and adolescents, but the FTC was not empowered to regulate the practice of advertisers or their communication platforms so as to protect children, and it was specifically instructed to cease monitoring. The food and beverage industry's commitment to self-regulate what and how it markets to children is widely acknowledged to have failed to reverse or change either these marketing practices or children's diets. A number of countries have instituted regulations and/or bans related to the marketing of unhealthy food to children in their efforts to prevent diabetes in younger people. These strategies have been shown to significantly reduce children's exposure to unhealthy food environments. In fact, Chile's 2016 food labeling and advertisement regulations contributed to a 23.7% reduction in household-level consumption of sugar-sweetened beverages, as an example. With that background, we recommend that the FTC should be provided the authority, the mandate, and the requisite resources to A, create guidelines and promulgate regulations through notice and comment rulemaking based on consultation with CDC, FDA, and USDA regarding food and beverage advertising to children aged less than 13. B, the FTC should restrict commercial advertising and marketing to children less than 13 years of age by advertisers, networks, and online platforms of specific types and foods and beverages that contribute to unhealthy dietary patterns as defined by the U.S. Dietary Guidelines. C, enforce these regulations by being able to send compulsory process orders to food and beverage manufacturers, sellers, and platforms who are in violation of regulations. And D, actively monitoring the practices of all food and beverage advertisers and any associated networks and platforms by routinely accessing marketing and advertising information about their work to enable regulation and enforcement and report on industry progress over time. This recommendation is open for questions or comments.
Hi, this is Kara Elam. I have a question. How does this fit within the scope and specifically within the duty that the subcommittee is, or the duties that subcommittee are aligning to? I ask because this recommendation seems far removed from the clinical aspect of diabetes care. Thank you.
Thanks, Kara. Yeah, so this recommendation falls squarely under duty number 3, which relates to public awareness of diabetes risk. So education and awareness. Currently, what children are exposed to with respect to their education disproportionately involves marketing of unhealthy foods and with a near absence of counter messaging or counter marketing. In addition, this recommendation aligns with duty number 2, which relates to our providing counseling to patients who are at risk of diabetes, like we have a pre-diabetes clinic in our pediatric setting now at my hospital, where we are recommending that children avoid certain kinds of foods. Then they go home and they are either online or on television being advertised to eat the very same foods that in our 10-minute visit we have asked them not to be eating. I don't know if other members of the subcommittee would like to comment on the alignment.
I'm going to ask one more question, if you don't mind. But then we seem to be making a sweeping statement that most children are getting their education from television versus thinking about it from the classroom or the home environment. So we're giving a lot of power to the television, and that's my concern, making a sweeping generalization.
I don't know that we're making that generalization. The federal government, thankfully, does not have a role with respect to what parents teach their children, and if there is a family that is spending significant amount of its time teaching their children what to eat and to eat healthy or unhealthy, that is their prerogative to do. However, the Federal Trade Commission does have a responsibility to ensure that there is no deception in advertising, and based on prior law, children under age 13 are eligible to have their marketing regulated, specifically when it comes to internet content. So there's nothing particularly overreaching about this with respect to either the age group of the intended audience or the scope of governmental reach here.
I'm still having a hard time seeing how this relates completely to clinical care instead of generalizing to the entire population, but I will yield to another member.
Was there somebody else who wanted to talk here? Go ahead.
No, it's okay.
Yeah, this is Bill Herman. I don't think there's going to be a single intervention to target childhood obesity. It's a huge problem now, and there are a number of complementary interventions that have already been recommended across federal agencies, so this is just one.
Yeah, and again, Kara, I believe this aligns primarily with Duty 3, not Duty 2. Duty 3 relating to awareness and education.
I understand that. My question is, it seems that we're assuming the education comes from the television versus nutritional education in schools or at the home. We're just giving a lot of power to the television, and we're generalizing it for the entire population versus those who are at risk for diabetes.
So this is
Well, I think just briefly, I mean, the media research shows very clearly that actually children's decision-making around food and beverages is predominantly driven by the commercial environment, TV and online. That is not to say that there aren't other influences. We welcome those influences, and we're not regulating those influences. We don't have any standing to do that. I think your critique is I understand it, but I think it's clear that the majority of educational messaging that children get is from television and online, and at the same time, we are not asking for any regulation or impact on what families teach. We have in our prior recommendations made hopefully influence what is taught in schools based on some of the funding recommendations that Aaron described in recommendation 3.
Dean, you have about 5 more minutes to finish up.
Okay, so Aaron, if you can quickly go through recommendation 8.
Yeah, this is a new recommendation, so I want to quickly go through the background, and then we'll go through the recommendations. Breastfeeding has been associated with lower odds of type 1 diabetes and of obesity in offspring. Research has found that women who breastfeed enjoy a 30% reduction in the risk of acquiring diabetes and a lower risk of cardiovascular disease. Benefits associated with greater breastfeeding intensity and duration. There's a threshold effect at 6 months duration of breastfeeding. Breastfeeding promotion policies and programs have been guided by strategies in the 2011 Surgeon General Call to Action over the past decade. 4 out of 5 U.S. mothers begin breastfeeding at birth, but that number quickly declines to less than half. Rates have increased overall. Rates of breastfeeding have increased overall, but there remain racial, ethnic, socioeconomic, geographic, and occupational related disparities. Hospitals designated as baby-friendly with staff trained in maternal care practices based on the 10 steps have been positively associated with increased duration of breastfeeding and have positively impacted minority populations by decreasing disparities. A leading reason for mothers, especially low-income mothers, to stop breastfeeding is the need to return to work soon after delivery. Paid maternity leave for at least 3 months has been positively associated with breastfeeding duration, with women who return to work at or after 13 weeks postpartum having a 2 to 3 times higher odds of predominantly breastfeeding beyond 3 months and nearly 2-fold greater odds of breastfeeding for at least 6 months. Next slide, please. So with that background information, in light of that background information, these are our recommendations. 1, ensure adequate funding for federal programs that 1, promote and support breastfeeding, and 2, address persistent societal employment-based obstacles that lead women to shorten duration of their breastfeeding. And then such programs include the USDA, FNS, WIC peer counseling programs, HRSAs, MCHB's Healthy Start and Maternal, Infant, and Early Childhood Home Visiting Program, and CDC's Maternity Practices and Infant Nutrition, Infant Nutrition and Care. The second recommendation, NIH, AHRQ, IHS, CMMI, and USDA and others should conduct community-based and community-informed demonstration projects to evaluate the impact of combinations of evidence-based breastfeeding support interventions among minority and lower-income women. The third recommendation, 8C, update the 2011 Surgeon General Call to Action to reflect the current landscape of breastfeeding research and provide updated policy and program guidance for healthcare providers, public health officials, women, and families. The fifth recommendation, 8D, fund new federal grants to states for the purposes of increasing the number of hospitals and birthing centers designated as baby-friendly hospitals. Hospitals would use these baby-friendly hospital grants to train their staff in maternity best practices and provide technical assistance to effectively implement the 10 steps to successful breastfeeding. Next recommendation, expand workplace protection so that all mothers have reasonable break time and access to a private space for pumping and expressing breast milk. This includes mothers covered by the FLSA, which are non-salaried employees, and those who are not FLSA, who are salaried employees. The Department of Labor should also employ a monitoring system to ensure employer compliance. And finally, provide mothers with up to 3 months of paid maternity leave to care for and bond with a child following birth. This leave would be distinct from unpaid leave available to all employers as a result of the Family Medical and Leave Act. Sorry, that was a lot, and I know we didn't have much time left. But did anybody have any questions on these recommendations?
John Boltry here. Question number 8F. Are you asking for legislation to or just for federal agencies to provide on the paid maternity leave?
So we're looking for federal legislation. We could discuss that. I think there's different levels. There's either federal legislation or working with states to strengthen their maternity leave care. But I think the more straightforward one was federal legislation that would do this. Yes, but I think absent federal legislation, there's still a lot of work to be done. Yeah. Dean?
I think the confusion is a really good point to raise because our overarching recommendation at the top of the slide relates to federal agencies, and 8F reflects activities including but beyond federal agencies. So we'll have to correct that.
So we'll correct that, yes. I mean, I think we're looking at federal legislation, yes, yes.
So what was the intention, though, that federal employees should get 3 months paid maternity leave?
No, it wouldn't just be limited to federal employees. It would be broader than that.
Okay.
So just to clarify, you want a mandate for all private sector employees that all businesses, whether small or whatever size they are, that they automatically get 3 months maternity.
No, we could be more detailed about that. No, it wouldn't. So again, these recommendations, they're not, we could be more detailed. They would not be all small. It would be, we can get more detail about, it wouldn't be all employees. It would probably be employees with employers that over 50 employees. And so there are details we would put in here for sure.
Okay, recommendation number 9 is one other new recommendation that I'll spend just a little bit of time on, and then Bill, I will close because the other recommendations we've reviewed before. Does that sound okay?
Yes, sounds good. If you could finish up, though, in the next 5 minutes.
Yes, so recommendation number 9 relates to the ambient and built environments. The background is that attributes to both the ambient and built environments have significant population-level impacts on the risk of acquiring diabetes and its complication. First, research links ambient environmental factors such as air pollution, water contamination, and endocrine disrupting chemicals to metabolic dysfunction and diabetes. Disproportionate environmental exposure is an underappreciated contributor to racial, ethnic, and geographic disparities in diabetes. These include higher exposures to endocrine disrupting chemicals, multiple constituents of air pollution, such as particulate matter, water contaminated with heavy metals such as arsenic, PCBs, organochlorine pesticides, BPA, and phthalates. Reducing the individual and societal burden of diabetes should include educating clinicians and the public on environmental exposures that may increase this risk, strategies to reduce those exposures, and social policies to reduce exposure and address environmental inequality as a source of diabetes disparities. With respect to the built environment, it's been shown that walkability, green space, urban sprawl, physical activity resources, and active transport opportunities have been shown to be determinants of type 2 diabetes and its complications. Differences in these area-level attributes contribute to disparities in diabetes and its complications. Enhancing the built environment will also improve the ambient environment by reducing air pollution. As a result, we recommend that federal agencies should limit the extent to which their work contributes to individual and population-level exposure to environmental pollutants and contaminants that have been shown to be associated with the development of diabetes and/or its complications. In addition, the EPA and the National Institute of Environmental Health Sciences should ensure that appropriate environmental protections based on scientific evidence are in place to limit individual and population-level exposures and should implement appropriate abatement measures when necessary, prioritizing those exposures that contribute to diabetes disparities. Relevant pollutants and contaminants are present in the air, land, water, and in manufactured and household products, as I described above. 9B, all federal agencies, but in particular the Department of Transportation and Housing and Urban Development, should assess how their policies, practices, and regulations and funding decisions related to the built environment can be modified to prevent diabetes and its complications by enhancing walkability, green space, physical activity resources, and active transport opportunities. Priority should be given to those areas where mitigation of unhealthy environments would reduce diabetes disparities. Comments or questions on recommendation 9?
I think this is very good, and I like the way you've combined the pollutants and contaminants with green spaces and walkability, transportation, housing.
Yeah, I think that was Naomi's aha moment.
Dean, this is Paul Conlon. I'm struggling with recommendation 9A because of the fact that it's actually a rather broad-reaching recommendation, albeit you've included the keyword diabetes in there. But I fear that this has reached far beyond what might be viewed as diabetes specific. I can embrace recommendation 9B potentially as an add-on to some of the follow-on recommendations you have in 10 and 11 with regard to housing, because I think those fit naturally. 9A, I'm struggling to see how that can readily fit within the rest of the subcommittee's recommendations.
Let me see if I understand your question. I certainly agree with you that the recommendations 9A go beyond diabetes, but are you asking whether they are relevant to diabetes? Is that what your question is? Because there will be a number of health benefits to reducing exposures, that's for sure, but we are only focused on the fact that they are associated with diabetes incidence or metabolic control. Are you asking about the evidence behind that statement, which is a fair question? I'm just trying to understand.
Well, it relates to that in part, Dean, and that is that I think that there are some recommendations that you proposed that have clear and direct links to diabetes. This one, I think, touches on it, but its link is much more narrow, and the broader scope of this, I think, touches on much more than diabetes, and I would fear that that broader scope might appear that this recommendation is an overreach.
Yeah, it's an interesting question. I mean, 9B, if we take 9B as an example, I mean, there are also cardiovascular benefits, benefits to mental health. You know, there are a range of benefits to improving the built environment that go beyond diabetes. I think the same could be said for 9A. Now, granted, I'm not an expert in contaminants, pollutants, and their relationship with diabetes. And we did have a presentation by the EPA on this. Bill, did you want to comment, Bill Herman, on your thoughts on that question?
Yeah, so Paul, you're right. A lot of these contaminants have been associated with obesity, inflammation, cardiovascular disease, but as more people have looked specifically at obesity, the risk of or specifically at diabetes, the risk of diabetes is increased dramatically by exposure to particulate matter 2.5 and some of the heavy metals and so forth. So I think the literature is evolving very rapidly on this topic.
Other comments or questions? I think we should, I will say that we have a recommendation in our research recommendations to advance this area of research further. But I agree with Bill that the current evidence shows odds ratios that are in the 4 to 5 to 6 range for many, particularly for many of these endocrine disrupting chemicals. So it appears to be very strong associations. Whether causation can be inferred is obviously unknown at this time. And that may be what you're getting at, Paul. Recommendations 10 and 11 you have seen before: improve housing policies, expand smoke-free policies, and recommendation 12, you've seen all of these recommendations before on what we recommend federal research to focus on as we think about trans-agency work. And Bill, we can come back to it if we have time at the end if you'd like.
Great, thank you. We're about almost 15 minutes behind schedule, though we did start about 5 minutes late. We've had, I think, a good discussion after each of the presentations, so I'd like to push ahead to the Prevention Targeted Population Subcommittee update with John Boltry and Howard Tracer.
Okay. Thank you, Dean. Thank you, Bill. I see you can move on to the next slide. Okay, I just want to acknowledge and thank all our subcommittee members noted here. And I think on the next slide you'll see the regular government employees. But I want to thank all our subcommittee members for their continued work on our recommendations. We also want to thank all the members of the public and the stakeholders who submitted comments on our draft recommendations. We appreciate that input. We want to state that the subcommittee has reviewed all the comments and we've taken them into consideration as we've revised our recommendations. So with that brief introduction, let me just turn it over to David Strogatz for Focus Area 1.
Dave, you're muted.
No.
Go ahead, David. We can hear you.
Can you hear me now?
Yes, we can.
Okay. So I'm going to briefly go over the recommendations for this focus area. As I was saying, 3 of the 4 are fairly unchanged from what was seen previously. The first one, raising public awareness about prediabetes and the NDPP. It corresponds to the fourth charge for the Commission, that is methods for outreach and dissemination of education and awareness materials to the public, and so recommendations to increase support to the CDC for its campaign that's been going on with the Ed Council since 2016 to improve awareness of prediabetes and promote enrollment in the National DPP Lifestyle Change Program. And then a more specific recommendation to more effectively reach populations disproportionately impacted by type 2 diabetes risk, to identify and engage popular social media influencers with numerous followers in key target audience populations, to develop and post custom content on platforms focusing on prediabetes awareness and the urgency to prevent or delay type 2 diabetes, and then for evaluation and monitoring purposes, to continue tracking visits to the Do I Have Prediabetes campaign page and track completions of the prediabetes risk test with an expanded focus on the degree to which populations at increased risk are being reached in order to reduce disparities in both awareness and engagement in interventions. And I'm thinking perhaps for this focus area, let me go through the 4 recommendations and then we can have some discussion about or comment about any of the 4. Again, the second one also relatively unchanged from what you've seen before, and corresponding to the second charge to the Commission, federal efforts to support clinicians in providing high-quality care. The recommendation is for CMS to provide coverage for hemoglobin A1C testing when used to screen for prediabetes, and as mentioned in the background, this will then align that coverage with the recommendations of the 2015 United States Preventive Services Task Force, as well as the 2021 American Diabetes Association Standards of Medical Care in Diabetes, which cite all 3 tests of fasting blood glucose, oral glucose tolerance tests, and HbA1c as equally appropriate to consider in screening for and diagnosing prediabetes and diabetes. It is this third recommendation that has changed based on public comment, so I'll just go over this one a little more slowly and thoroughly. So in way of background, in 2019, an AMA technical expert panel proposed 3 electronic clinical quality measures for review by the National Quality Forum to monitor and improve quality of care for patients with prediabetes. And what I've done here is offer a very abbreviated description of those 3 measures: screening patients age 40 and older with a BMI greater than or equal to 25 for abnormal blood glucose at least once in the previous 3 years. The second recommendation, providing an evidence-based intervention for patients with prediabetes during the 12 months following determination of abnormal blood glucose. And 3, retesting patients for abnormal blood glucose in the year after they were identified with prediabetes. And to continue with background, while rates of screening for diabetes have improved, data from NHANES suggests there's still a substantial gap in awareness for adults with prediabetes based on levels of fasting glucose or A1C. Studies of patients, clinicians, and medical records also indicate low levels of referral for adults with prediabetes to receive individual counseling or participate in programs to reduce risk of diabetes. These findings underscore the salience of the proposed guidelines for improving timely diagnosis of prediabetes and implementation of preventive measures. And so the recommendations, first, that all federal agencies that directly deliver or influence delivery of medical care should implement the 2019 AMA proposed prediabetes quality measures related to screening for abnormal blood glucose, intervention for prediabetes, and retesting of abnormal blood glucose in patients with prediabetes, and also a recommendation to support implementation of these measures. Quality improvement programs should be introduced to improve performance and reduce disparities. So in this sense, this recommendation really corresponds to the 2 charges, the second one for supporting high quality care, and the 4th charge to the Commission for education and awareness materials, and this time to health professionals, whereas the first recommendation focused specifically on the public. The final recommendation in this focus area, again, is similar to what we had drafted before. It relates to that second charge of providing high-quality care. And for federal agencies that deliver care, we have our examples here, should implement a process for systematically using administrative and clinical data to identify patients at risk for or already meeting criteria for prediabetes and to confirm appropriate follow-up. And so the sense of this recommendation is to make use of data that already exists to create registries as cited in the background here so that individuals could be contacted by clinic staff to discuss prediabetes, definitive diagnostic testing, and opportunities to enroll in the national DPP, and then flagging those records for reinforcement of the messages at future visits. So those are our 4 recommendations. As I mentioned, it's the third one that changed via public comment. I should also add that let's see, I'll go back to that page. This third recommendation, providing an evidence-based intervention for patients with prediabetes, is currently on the MUC list for CMS that was listed in December of 2020. And let me finally conclude by mentioning that the interventions that are mentioned include referral to a CDC-recognized diabetes prevention program, referral to medical nutrition therapy with a registered dietitian, or prescription of metformin. So those are the 3 that are mentioned in terms of evidence-based intervention. And with that, I'll open it up for any questions or comments about the 4 recommendations for this focus area.
David, this is Dean Schillinger. Thank you for your presentation. I wanted to, if you could advance the slide to slide the number 4. So yeah, first of all, I wanted to thank you guys all for including the Federal Bureau of Prisons in the agencies that deliver care. It's a bureau that we had insufficient time to look much into. I wanted to get a sense of what your recommendation means to people who are incarcerated. What does it mean to confirm appropriate follow-up if a prisoner is found to have prediabetes?
I think it would relate to the quality measures on the previous slide. So if someone's identified with an abnormal blood glucose that's in the level associated or defined by prediabetes, then to see if in fact there's recommendation for let's say metformin. Obviously for someone who's incarcerated, the other recommendations may be logistically impossible.
This is Sherry. I just had, I feel like this may have been a recommendation somewhere else, but I just wanted to ask, it looks like these recommendations are around federal agencies, not CMS putting it into their sort of ECQM measure, or is that, I just can't remember if that's somewhere else or if you're trying to specifically just focus on those that deliver care and not CMS.
Well, I think for the, referring to the second recommendation, that obviously would have implications beyond federal agencies. For the others, I think that our guidance was
sorry to interrupt.
Related to the charge for the commission.
I wasn't this recommendation. I think it was the one around putting it into their ECQM. You had it for like clinical quality measure somewhere.
This one.
Right. So I guess in here, are you envisioning that CMS would also do this, or is this just, it's not clear to me, I guess, if this is involving CMS or if this is like
FDA
or...
Yeah,
okay.
I believe it would. We had actually, in our previous version of this recommendation, we had just made reference to this first one, screening patients, and we revised, from public comment,
that it would really make sense to have this full set of 3 recommendations that were offered. And as I had mentioned, this is all, the second one is the one that's actually now under consideration, via the CMS MUC list for, shown in 2020, December, and presumably being under consideration currently.
Okay.
I don't know if Barry has any more insight or comment about that.
Thank you. No, I think that accurately describes the current state. Thank you.
So if there are no other comments, then perhaps we should move on to focus area 2.
Hi there, it's Shannon.
Hi Shannon, we can hear you.
Okay, great, thank you. All right, so focus area 2, our focus area has been focused on improving access to and utilization of evidence-based effective type 2 diabetes prevention interventions. Next slide. So recommendation number 1 is surrounding metformin and its use in prediabetes. Metformin has been approved by the FDA for treatment of type 2 diabetes since 1995, and there's a body of evidence to support the use of metformin in delaying the onset of type 2 diabetes in individuals with prediabetes who are at high risk. And metformin, unfortunately, does not have FDA approval used for prediabetes. So the FDA, as I mentioned, has not approved metformin for the treatment of prediabetes. And these implications in terms of coverage and payment and prescribing are, may be significant. Prescribing of metformin is considered off-label use, and individuals, clinicians may not prescribe it for that reason. Due to the multiple generic versions of metformin, there's really little financial incentive for any pharmaceutical company to pursue an indication for metformin in patients with prediabetes. And while certainly other individuals could pursue that indication through the FDA, they may be unwilling or unlikely to do that due to the costs and responsibilities that would go along with such an undertaking. Next slide. So our recommendation, the NCC's recommendation, is to provide funding to the NIH to collect, analyze, and organize the available data from the Diabetes Prevention Program describing the effectiveness and safety of metformin for diabetes prevention in patients with prediabetes, including subpopulations most likely to benefit. And such a summary could then inform an appropriate submitter's request to the FDA, potentially in the form of a citizen's petition, to review and consider an indication for the use of metformin in high-risk patients with prediabetes. Any questions there? All right, thank you. We'll go on. All right, recommendation 2 is surrounding modes of delivery of evidence-based interventions. There's significant evidence with delivery of evidence-based interventions to delay or prevent type 2 diabetes using a variety of modes, including in-person, online, distance learning, and telehealth across federal agencies. There's variation in coverage by private and public payers for these various modes of delivery that have evidence of successful participant outcomes in delaying or preventing type 2 diabetes. The National Diabetes Prevention Program quality standards are revised every 3 years based on a review of the literature, analysis of participant data, and feedback through public comment. There are barriers to access to evidence-based type 2 diabetes prevention interventions. and offering these interventions through a variety of delivery modes may increase access. However, coverage for alternative delivery modes varies across payers. Our recommendation is to promote coverage for all proven effective modes of delivery, in-person, online, distance learning, telehealth, for evidence-based interventions that produce successful participant outcomes that meet or exceed those of the DPP research trial in preventing or delaying the onset of type 2 diabetes.
Shannon, this is Carol. Is this directed at CMS or is it directed at all federal agencies that provide care?
Yeah, this one is related to all.
And Shannon, this is Bill Herman. That might be a fairly high bar. I wonder if it should be to meet or exceed those of the national DPP.
Yeah, that has been an ongoing discussion, Bill, and we did receive some comments from stakeholders about what actually the National Diabetes Prevention Program tracks and what those outcome measures are. And so that is why we modified it to meet or exceed those of the DPP in terms of its delay or preventing type 2 diabetes.
Though when one looks at the resources used in the DPP clinical trial, they were enormous. It was basically a proof of concept, and I think the challenge is to deliver the intervention in a more cost-effective manner such that it can be more widely disseminated. So again, I would perhaps look to be not inferior to the national DPP as it's currently implemented.
So, Bill, you're just suggesting that we say meet or exceed those of the national DPP rather than the DPP research trial?
Yes.
Yeah. And Bill, would that mean that, or to the subcommittee, would that mean that every new entity that has a national DPP type intervention would need to do an efficacy trial to demonstrate its effectiveness and then before scaling?
Can you repeat that again?
I'm just wondering what the criteria would be to determine whether an entity has proven its value. Do they need to do a randomized control efficacy or effectiveness trial before they would get approved to be reimbursed in this fashion?
So I think DPP providers, as part of the national DPP quality standards requirements, do need to provide, it's not a clinical trial, but they need to provide results from their programs before they're accredited, I believe.
Yeah.
Pat could probably
That's
comment
correct.
on that.
That's correct. Pat, do you want to comment a little bit about that? Pat?
Sorry, I was having some trouble getting my mic off mute. Can you all hear me?
Yes.
Yes.
Yeah, that is correct. I think part of the issue, yes, we do. The bottom line is yes. In order to achieve recognition, and there are different levels of recognition. When you get to full recognition, yes, you have to show that you have achieved outcomes in your participants that are equivalent. Basically, we had a 5% weight loss. Those outcomes have since been updated with the new 2021 standards. So there's an additional couple of outcomes that equate to the 5% weight loss that we also accept. So we do collect those data. We don't go so far as following participants long term, however, to look at incidence of type 2 diabetes developing. That is something that the national DPP doesn't do and never has.
So this is Carol. Just to clarify, if a program wants to get paid for, in addition to in-person, they're going to have to prove the efficacy of their online program independent of the efficacy of any other DPP online program. Is that right? Every program is going to have to prove the modes in which they show efficacy. Is that correct?
Well, so
in order to get paid.
Yeah, this is Shannon. I mean, so our statement really is to promote coverage for all proven effective modes of delivery. So I think, you know, we have been fortunate to have evidence over the past year of some effective interventions, and I don't know that we've defined proven. I think all payers would then, you know, be able to define their requirements of what constitutes that. Obviously, we don't want, you know, it doesn't make a lot of sense to have unproven modes being delivered when we know we have proven modes.
Shannon, this is Paul Conlon. If I understand the way this recommendation is worded, it has two components that have been called out that probably need clarification. One is that you're seeking that reimbursement be provided for the modality in which the program is delivered. And you've given a few examples, in-person, online, or distance, assuming that there's evidence that those modalities are effective. And then the second component is the benchmark upon which those are going to be evaluated, which I think, as Dr. Herman mentioned, sets a fairly high bar, given that clinical trials usually provide the most controlled environment for an efficacy evaluation, and real-world experience usually, if not always, is much less than that. So some other external benchmark should probably be used if you're going to actually propose a benchmark. But I think probably the more important component is what others have picked up on, and that how do you reconcile the modalities of delivery as being effective.
Yeah, I think so. We had these conversations among our work group, and I think, you know, the general consensus is we do know the National Diabetes Prevention Program is effective, and so that why would we have other why would we provide sub or inferior care if we know that that's effective? So that is the benchmark, right?
And I think the problem is that historically the requirement was that the programs be delivered in person. And now other programs have shown that delivered virtually, they can achieve the same outcomes. So they should now be covered.
Right. Right. So yeah, and I think that's the case. If they can achieve the same outcomes, then they should be covered. And the strategy would be different if they can't achieve the same outcomes. Then our tactics for caring for people with prediabetes might need to change. Then it may become an access issue. Any further thoughts?
Shannon, we should probably move on.
Yep. Thank you. All right. We have combined recommendations 3, 4, 5 into one group, so you may see these slightly in different order, different grouped together in a different way. So the Social Security Act established the CMMI, the Center for Medicaid Innovation, to test innovative payment techniques and service delivery models. The MDPP was one of those models tested, and based on the positive results, the model was officially expanded into Medicare in 2016, rolled out in 2018. Now that model expansion is being evaluated. It is a covered service rather than a covered benefit under the model expansion, pending the results of that evaluation. And there is also once-in-a-lifetime limit on the MDPP service. Based on the findings of the original diabetes prevention program research trial, subsequent studies demonstrating the program's effectiveness in non-clinical settings, and in the 15-year results of the DPP outcome study, the intervention has been studied extensively and has substantial evidence supporting its effectiveness across settings and populations. The future of the MDPP as a covered service, next slide if you would, the future of the MDPP as a covered service will be determined, if you would go on to the next slide, if it as a covered service will be determined by the outcome of the expanded model evaluation. Full virtual delivery of the MDPP is not currently included under the expanded model, and this may limit CMS's ability to enroll a sufficient number of Medicaid beneficiaries required to evaluate the expanded model. Virtual delivery of makeup sessions is part of the MDPP expanded model. However, under the national DPP, virtual delivery is permitted. And virtual delivery organizations must meet the same CDC national quality standards and achieve the same participant outcomes as in-person delivery organizations. During the COVID-19 pandemic, CMS issued flexibility allowing for virtual delivery of MDPP services. In addition, there may be variables that impact participants' ability to fully engage in or complete the program that may warrant additional intervention, and there may be a dose threshold. The NCC recommendation surrounding this topic are: 1, approve MDPP as a permanent covered benefit, not only a model expansion service; expand coverage of MDPP to include virtual delivery, and to lift the once-in-a-lifetime limit on participation in the MDPP. I'll stop there for questions. Okay, I think I'll go on, in the essence of time, to recommendation 6. And this is also, this particular topic is related to the national DPP and the MDPP. In response to the growing rate of prediabetes and diabetes, Congress authorized the CDC to establish the National Diabetes Prevention Program in 2010. It's a private-public partnership that works together for a lifestyle change program, as you all know. The National DPP provides a framework to create a trained workforce of life coaches, national quality standards supported by the CDC Diabetes Prevention Recognition Program, and a national network of program delivery organizations sustained through public-private payer coverage and for a participant referral and engagement process. CMS and CMMI and CDC collaborate to meet joint agency priorities related to the Medicare Diabetes Prevention Program, the MDPP expanded model. And the CDC revises its Diabetes Prevention Recognition Program standards and operating procedures every 3 years in response to changes in the scientific literature, data from organizations participating in the program, and there are additional requirements for programs to bill Medicare. Next slide. Some organizations, particularly in rural and underserved areas, experience challenges achieving preliminary or full CDC recognition and applying to become MDPP suppliers. Our recommendation is to continue efforts to streamline the CDC recognition process and the CMS payment process for the national DPP, MDPP, and MDPP while maintaining quality, standardized program eligibility, and duration differences between the national DPP led by the CDC and the MDPP led by CMS. Pause for questions, anything? Okay, hearing none in the essence of time, I'll go on to draft recommendation number 7. The physician fee schedule rules establish the benefit structure and payment rates for the MDPP based on the Diabetes Prevention Program model test. The payments are adjusted annually by the 12-month percentage change in Consumer Price Index for the period of June 30th of the year to the preceding update year. The current MDPP payment model offers reimbursement only when participants reach certain attendance and weight loss benchmarks. Under the model, program delivery organizations assume a level of risk and may be under-resourced to cover the upfront costs associated with the program certification, marketing, and participant engagement and enrollment. More recently, large, primarily virtual program delivery organizations have been able to negotiate different payment rates schedules with other insurers and employers that address some of the barriers in the current MDPP reimbursement model. Reimbursement rates may not fully incentivize centers and programs to apply for certification. Current MDPP program payment rates may not be sufficient to cover the expenses of many program delivery organizations. Currently, only a limited number of eligible organizations with CDC preliminary or full recognition have applied to become MDPP suppliers. Reimbursement rates may have a disproportionate impact on smaller and rural programs. Next slide. So the recommendation is to provide funding to support the testing of new financial models that will offer greater upfront payments and more equitable risk sharing between payers and MDPP program delivery organizations, and increase the level of funding to make Medicare DPP programs sustainable. Okay, I'm going to go into recommendations 8 and 9.
Shannon, just a second. Who is that recommended to? CMMI or CMS or the new?
Yeah, so this would be CMS because this is the MDPP. Yep, it would be CMS because it's MDPP.
I think we need to go ahead.
Okay. Sure. All right, draft recommendation 8 and 9 are around Medicaid coverage. So Medicaid coverage for the national DPP is a state-level decision. There is significant variability across states in terms of whether the national DPP lifestyle change program is made a covered benefit under the state's Medicaid program, and there are variability in delivery modes and level of reimbursement authorized. Risk factors, as we know, for type 2 diabetes are often higher in the Medicaid population. Our recommendation is to provide financial incentives for states to cover the national DPP and other evidence-based interventions that produce successful participant outcomes that meet or exceed those of the DPP research trial preventing or delaying onset of type 2 diabetes within their Medicaid programs, and to promote state coverage of all proven modes of delivery, in-person, online, distance learning, telehealth, for evidence-based interventions that produce successful participant outcomes that meet or exceed those of the DPP research trial on preventing or delaying onset of type 2 diabetes and delaying or, that's a repeat, my apologies. And so the same questions I would imagine would come up related to this comment as they did earlier in the national DPP related to whether or not they meet or exceed those of the DPP research trial versus the national DPP.
Yeah, and again, I would recommend that the national DPP be the benchmark.
So I'll take that back to our group. It has, that wording is shifted a time or two. Or 3. All right, and I'm going to go into the next one if there's no other questions in essence of time. And as Dean mentioned earlier, there has been some conversation about joining these or kind of developing a joint recommendation related to some interagency coordinating body. And I think the general population group recommended an office of natural for diabetes. And this recommendation is similar but slightly different. So originally mandated by law in 1974, the DMICC was chaired by the NIDDK and includes other agencies in the Department of Health and Human Services and a few other non-HHS federal agencies that support diabetes-related activities. DMICC facilitates cooperation, communication, and collaboration on diabetes among these governmental agencies. And this approach is designed to help ensure that federal diabetes activities are coordinated and not duplicated, and that stimulates collaboration across agencies. The issue is there's a lack of understanding on how the statutory authority and scope of the DMICC align with the recommendations of the NCCC, the National Clinical Care Commission, for a federal interagency coordinating body within AHHS to review, support, promote, and implement proven evidence-based policies, programs shown to be effective for the prevention and treatment of diabetes. Our recommendation is to identify or establish a federal interagency coordinating body across HHS and relevant non-HHS federal agencies to review, support, promote, and implement proven evidence-based programs shown to be effective in preventing or delaying type 2 diabetes. So as you can hear, that recommendation does have a significant amount of overlap related to the recommendation in the general population group.
This is Sherry. So are we thinking of combining this in some way?
Yeah, so that,
like combining this recommendation?
Yeah, so that discussion has started, and I think, you know, there's the more recent communications about that recommendation are, you know, one is a federal interagency coordinating body, one is an office. So I do think the commission will need to have further conversation on how to combine these recommendations into likely one recommendation that goes across the work groups, the subgroups. Any further questions? No, thank you.
No, I would just like to comment, this is Dean, that we support the consolidation. The one concern we had from our subcommittee was our prior communications with the DMICC made it clear that the DMICC didn't really have either the authority or perceived its role to engage in anything related to federal policy and practices, but really has been serving more as a forum to exchange ideas between research and ideas between and among agencies.
Good. Thanks, Dean. I think we should go ahead with the focus area 3 now.
Okay. Thank you, Shannon. I want to thank my co-members on Focus Area 3, which is the sustainability of type 2 diabetes prevention. Next slide, please. Next. Okay, great. Thank you. So this slide is basically to point out two things. You'll probably hear about the DPP a lot, and you've heard about it a lot, but the DPP study showed that lifestyle intervention and metformin were effective in reducing the risk of diabetes, but the study lasted approximately 3 years. And we really don't know the optimal strategy to sustain the prevention of diabetes over the longer term. This focused area had a recommendation about research to determine that, and we've revised that and moved it into focus area 4. So if you're looking for that recommendation, we've altered it a little bit. But the important background here is that we don't know how to sustain diabetes prevention, or we don't know the best way to sustain diabetes prevention longer term. Next slide, please. And so with that background and knowing that we have a call for research to demonstrate effective ways to prevent type 2 diabetes in the longer term, again, think 5 to 10 years, not 1 to 2 years. So we have that research call. This recommendation, though, is about implementation of that diabetes prevention strategy once the research, once studies sort of determine what that effective way is. So to read the background, because this is a little bit changed from last time, once research demonstrates effective ways to prevent type 2 diabetes longer term, their prompt implementation is crucial in order to realize that benefit to people who have prediabetes, and insurance coverage of an intervention or a service is a major determinant of its availability and implementation. And if that insurance coverage is lacking or reimbursement is insufficient, then the availability and implementation of that longer-term type 2 diabetes prevention intervention is going to be hindered. It won't be able to be implemented. And so our recommendation to CMS is that the Commission recommends ensuring that prompt coverage and sufficient reimbursement to cover all program costs are included in the public payment system for evidence-based strategies that are shown to sustain long-term type 2 diabetes prevention. I'll stop there for a second because we don't have a lot of recommendations for this focused area. So, questions? Comments?
Can you clarify how this recommendation maybe differs from some of the ones we saw before? Is it the promptness? Is it the comprehensiveness?
We discussed this a fair amount, where this belongs and can it be sort of folded into another recommendation. We decided because I'll just say it, because the context is different, it didn't fit neatly into ones about proven ways of preventing diabetes with the NDPP or MDPP. It's a bit more future looking, and that's the difference. So it does need, we know that it needs a home somewhere. We're not exactly sure where it fits in, but we did, at least as a committee, favor keeping it as a separate recommendation. And I appreciate that we have several recommendations around coverage and reimbursement. So it may be possible to move this into a different focus area. After one of the recommendations that Shannon just went through, I was thinking about that, but it's a different context, so it would still have to be a standalone recommendation, I think. It would either confuse the recommendation it was part of, or it wouldn't come out clearly.
And can you clarify the decision to limit this to public payment systems as opposed to including it as a covered preventive services as the Affordable Care Act does with private sector insurance companies with other preventive services?
Well, I mean, I think it would be great if it was covered in the private sector, but I feel like that, and maybe I'm wrong, so if you can, I guess, reframe it, but I think that might be beyond the scope of the Commission. So I don't think we can make recommendations around private insurance coverage. There are ways that I guess insurance companies are mandated to cover preventive services. And I don't know that we can necessarily mandate or recommend that as part of that Commission.
Howard, this is Paul Conlon. Thank you for highlighting the parts of the recommendation that stand out. And so I'm going to focus on a couple of aspects of the red.
Sure.
Is it, in using the words prompt coverage, is it to basically say that if a program is, a new program is shown to be effective, that it should be included in coverage determinations? My reason for asking that is one of the things that we have covered in our subcommittee is the idea that there should be an evergreen type evaluation whereby what is covered now should not be considered case closed, and there should be some regular and recurring reevaluation of, for example, we're applying this to technology, that coverage determinations should be something that are regularly and routinely reevaluated. So is that what you were trying to get at with this?
Yes. So that actually sounds like a bit of a closer fit if you're talking about technologies that haven't yet been proven or maybe will be developed next year. Yeah, that is closer to what we're recommending here. So once we know what works longer term for diabetes prevention, exactly, it should be promptly covered and sufficiently reimbursed.
Yeah, this is John, and the sufficient issue was that all of the costs of these programs are not covered by the current reimbursement.
So we'll have to talk offline, Paul. And of course, when you present, I'll take a look at that recommendation. So thank you. Should I move on? Okay. Next slide, please. Okay. And then the second recommendation is going to be around sustainability of type 2 diabetes prevention at the federal programmatic level. You've seen this slide before about the need to prevent diabetes and how important that is. So let's go on to the next slide. And this is what's new in this recommendation. We're specifically calling out one program. So before we said diabetes prevention is important for the federal government in a larger sense, and here we're calling out HRSA's Delta States Network Grant Program, which provides network development grants to 8 states in the Mississippi Delta. I thought in a different version I had the states listed. They weren't all in the Mississippi Delta, so it included some Midwestern states as well on the Mississippi River. But anyway, to develop and improve rural health infrastructure. The program requires grantees to focus on diabetes, cardiovascular disease, and obesity, though not specifically diabetes prevention, and that's where we see the opportunity. So the program would benefit from additional resources to allow it to include diabetes prevention as a focus, but not taking away from the other important aims of the program itself or the agency. So next slide, please. We'll summarize that. Okay, the background again is about the importance of preventing diabetes, and the problem is that funding priorities can shift over time, and federal grants to improve community health may not specify diabetes prevention as a priority, which we think it needs to be one of those priorities. So federal agencies focused on disease prevention should continue or increase their current level of funding to prediabetes detection and evidence-based type 2 diabetes prevention. And we specifically are calling for more resources to HRSA's Delta State Network Grant Program to allow that program to include diabetes prevention as a focus. Questions, comments?
Howard, this is Carol. Right now it's just diabetes outcomes for people who already have diabetes, and you're wanting to add diabetes prevention. Is that right?
It allows, yeah, it allows the, I guess the grantees to focus on the aspect of diabetes, of type 2 diabetes that they want to, but it doesn't sort of specifically call out diabetes prevention. We think that, again, we don't want them to take away from treatment of diabetes, diabetes education, et cetera, but we do want them to additionally focus on prevention of type 2 diabetes.
Thank you.
How do you, this is Sherry, how do you handle this continue or increase? I mean, are you going to specify something so that some agencies know to continue and some know to increase?
I think that we decide, okay.
Because I would think that anybody who didn't want to do it.
I'm sorry, Sherry.
I was just saying, like, if we're not gonna, I don't know if we're increasing funding so that they can increase. It just seems a little vague. You may want to specify or make it more clear.
We don't want to specify certainly a number or to tell them, well, you should increase by X percent, and that's honestly why we left it open like that. So I hear what you're saying, and certainly am open to suggestions. In some ways, it was done purposefully.
I guess I'm not, if we leave it too open-ended, does anything change? It's just a question. I know we've handled this to try, like, add some text for other recommendations to say to meet X, to meet unmet, etc. But I don't know how you would define that for this particular area. I guess I just worry that we're going to put a recommendation out there that doesn't change anything.
Right, no, any suggestions? I know that we're a bit constrained, so we may have to follow up offline.
Yeah, and I don't have an answer for you. I just something I'm noticing.
No, I know that something that we'll need to work out. Thank you. Okay, I think we can go on to the next focus area.
Thank you this is John Boltry. Thank you to subcommittee members of Focus Area 4 and all the members of our subcommittee. As Howard mentioned, we combined some of the recommendations from Focus Area 3 with Focus Area 4. I'm going to point out only the new and revised language in the background and recommendations. So next slide, please. There's nothing new in this background. Next slide, please. Now, what's new here starts in the middle. For example, in the DPP, 29% of those in the placebo arm progressed to type 2 diabetes mellitus over 3 years, and over longer follow-up, 52% of those in the placebo group progressed to type 2 diabetes mellitus over 15 years. The best way to prevent the progression of prediabetes to type 2 diabetes mellitus in the long term is uncertain. Next slide. What's new here, we say alternate medication choices are needed for people with prediabetes. And then the last sentence, more research is needed to better identify those people with prediabetes who are at high risk for developing diabetes mellitus and complications so that screening and interventions can be tailored to maximize effectiveness. Next slide. So what's new here are our recommendations. 3 to 6 are slightly reworded, so I'm going to go over those. 3 is to study programs that combine both lifestyle intervention and metformin to prevent diabetes mellitus. 4, to study and develop new medications that safely and effectively delay or prevent the onset of type 2 diabetes mellitus and its complications. Next slide, please. 5, to understand the number, frequency, duration, and content of lifestyle intervention sessions needed to effectively prevent diabetes in the long term. 6, to understand and mitigate barriers to long-term maintenance of weight loss achieved in diabetes prevention programs. And then 7 is an entirely new recommendation to disseminate new knowledge about effective in-person and virtual diabetes prevention programs, to whom and how to do it, create education programs for the general public, for health professionals, providers, and for policymakers. And this directly addresses charge number 4 to the National Clinical Care Commission. Comments or questions about those?
Can you put up the first 4 recommendations again? Okay. Sorry, this is Dean. I just had a quick question. I know we've discussed this in prior meetings, but I'm not sure if we landed anywhere. The idea of trying to develop new diagnostic tests, whether it's metabolomics or other kinds of technologies that could identify the subgroups of prediabetes patients who are at greatest risk of progressing to diabetes and or likely to benefit the most from a DPP-like program. Has that just didn't hit enough of a priority? My only concern is that the cost of scaling up the DPP to whatever 30 to 40% of the United States, if only a subgroup really is likely to benefit, is significant. So just trying to think about a way to ensure that our tax dollars are used as efficiently as possible.
Could you go back one slide, please? What we did, if you look at the last two sentences here, is we put it in the background. So finally, people with prediabetes are a heterogeneous group. Individuals have different physiologic abnormalities that contribute to this glycemia, so that some people with prediabetes may develop diabetes and other complications more quickly than others, and more research is needed. So we put it here. We had discussion about this. I know Howard and Barbara and the others in our subcommittee were concerned with not wanting to limit funding to this specific area, but to call it out specifically. So that's how we did this, Dean. I mean, we could reconsider putting that back into a specific recommendation. This is kind of how we settled on that.
Yeah, I appreciate it being there. I don't know that the other recommendations necessarily flow from it, though. Was there concern about making a specific recommendation about trying to develop more predictive serologic tests or other forms of risk stratifying?
I don't remember the specific wording, but as I recall, there's not impediments to that funding now. A lot of that is going on and happening as a natural cause of diabetes research.
I see.
But you know, we can discuss that again. We'll bring that back to our group and see if we want to include anything specifically about that.
Thank you.
Thanks, Dean. Let's go on to the any other thoughts on the recommendations for this. Let's move on to type 1 diabetes. There's nothing new in this background statement. Let's move on to the next slide, please.
Hi, this is Stephanie.
Yes. I'm sorry, I'm not hearing you.
Let me try again. Is that better?
Yes.
Is any
Not hearing you again.
Is there anything in your subcommittee, any discussion in your subcommittee about Medicaid funding research for DPP and some of the demonstration programs that looked at different Medicaid models?
You were going in and out. I heard, is there anything in our subcommittee about Medicaid funding? And this particular area is dealing with research. I couldn't quite hear your question.
Yeah, I'm sorry, John. It's Medicaid research on the different Medicaid models, some of the demonstration projects that are on Medicaid demonstration projects, looking at prospective versus fee-for-service for DPP.
What I think I heard you say, is there any research looking at the Medicaid models? I think you meant CMS models looking at funding the DPP.
Well, not necessarily CMS, just at the state level. So it's from our lens, looking at federal mechanisms to use the existing state-level data on the Medicaid model. Does that make sense?
So using the existing state-level data on the different Medicaid models that are used in states to see if they are effective?
Yes.
And you think we should have a recommendation to do research on that?
Or some level of investigation of that data.
Yeah, that could be
something
that could potentially be an interesting natural experiment to see if different state Medicaid coverages for the TPP are associated with different outcomes in the state Medicaid populations.
Yes.
Though I think time is short now, and I think we maybe should take that up within the subcommittee later on. So, John, if you can finish up.
Yeah, maybe you can send us your recommendation to consider in an email. That would be great.
Happy to do.
So, thank you. So let's go on. So there's nothing new. Let's see. So what's new in this slide is the last couple of lines. Work is needed on how to best leverage emerging data from TEDI and TrialNet to develop precise and effective screening programs that can be used to identify those at high risk who might benefit from interventions, and advance research to prevent type 1 diabetes mellitus onset altogether. Work is also needed on efficient and cost-effective methods for screening the general population for type 1 diabetes. And so, some interesting data has emerged in the last year that looks like there might be medications that can help to delay or possibly prevent type 1 diabetes. And there's also been some screening methods that are emerging. So that was the reason for adding this wording. Next slide, please. And we also added the last sentence here, which has to do with the Special Diabetes Program, which has funded much of this research, and that is that the funding for the Special Diabetes Program has been level at $150 million since 2004. And next slide, please. So we don't have a new recommendation. The understanding for our committee of the level funding since 2004 just came to light actually over the last couple of days. So we're there's no new recommendation yet, but before our next meeting at the end of June, we expect to have a recommendation that's going to address the funding level that we will add to the type 1 diabetes prevention research recommendations. So any comments about this recommendation?
And John, I think your first recommendation really is to screen the general population type 1 diabetes risk. Is that correct? Not really for type 1 diabetes. That's pretty apparent.
Funding the recommendation, funding the Special Diabetes Program in 5-year increments so that new innovative research can.
The one before that about population.
Well, that wasn't a recommendation. That was just part of the background.
Okay.
So
okay.
No, please go forward on the slides. Next slide. So.
Okay, I understand. Yeah. So that might be.
That was just part of the background, and so we're going to add another recommendation. We just haven't. This information is so new. We haven't done that yet. But we have an idea of what we want to say, but we haven't vetted that in committee yet.
Okay.
Hey, John, if you can hear me, this is Ellen.
Yes.
It might be worth pointing out that also the SDPI is funded for Indians is funded also at $150 million and has been flat since '04.
Yeah, thank you, Alan. And the reason I didn't bring that in here was because the SDPI is more than just research. But yes, I do think that needs to be included. I'm not exactly sure where, so thank you for reminding me about that. We'll be sure to bring that up in our next committee meeting as well. Any other thoughts or comments on Area 4? Okay, thank you.
Good, and is that it then, John, for your subcommittee?
Yes.
Good. Okay. So we're running about 20 minutes behind. We are scheduled for a break now. I'd like to go ahead and take a more or less 15-minute break. Let's reconvene at 3:45 Eastern Time, so actually in about 12 minutes if we can.